Good afternoon, everyone. I'm Todd Didier, Communications Director at the Primary Care Collaborative, a national organization that convenes stakeholders from across the healthcare landscape that are committed to improving the nation's health by strengthening primary care. I'm thrilled to welcome you to today's webinar, Learning from Leadership, Employer Innovators Seeking to Scale. We have a fantastic panel ready to discuss how employers are helping improve the health of their teams, their communities, and our nation by strengthening high quality primary care. Just a few housekeeping items before we get started. This session, like all PCC webinars, is being recorded. We typically post all of those recordings on our website within 48 hours, and you can find all previous PCC websites on the pcc.org as well. We will be taking audience questions at the end, but please feel free to submit them throughout the entire webinar using the Q&A tool at the bottom of the screen. As I said, feel free to send those. We'll dedicate about the last 10 minutes for Q&A. With that, I'd like to go ahead and introduce our moderator. Laurel Pickering is President and CEO of the Gateway Business Health Coalition, where she helps support employers in their efforts to enhance the quality and overall value of their investments and health benefits while seeking to improve the health of their enrollees. Laurel, thank you so much for joining us today, and we're thrilled to have you.
Thanks so much, Todd. I'm thrilled to be leading this conversation, which is actually a reprise of a panel that we did at the PCC conference. So it's great to be back with Bryce, Lowell, and Lee. Before I introduce them individually, just a little bit of a highlight on what we're going to be talking about. I think, we see more and more that employers are understanding the value of primary care and what it brings to their employees, both in improved health and then what it brings to them as employers in reduced cost. And we have a nice cross section of the industry. So we have Lee, who works for the HTA. We'll introduce him momentarily, but works with larger employers. And then we have Bryce, who's a consultant working with mid-size and smaller employers. And then Lowell is actually an employer. So this is a great group to represent the various perspectives and what employers are doing to bring primary care to their employees, and high quality primary care as well. Before we started the webinar, we were already having a conversation about how we can ensure high quality and great patient experience once we put primary care in place for our employees and members. So let me introduce them before we get our conversation kicked off. We're thrilled that we have an actual employer. So Dr. Lowell Fernander is the Vice President of Benefits and Wellness and the Chief Medical Officer at Rocket Companies. And he's an internist, a practicing internist, and is focused on championing a comprehensive strategy for employee health and well-being. Bryce Heimbaugh is CEO of IE Enris Management Consultants, which is employee benefits consulting firm, happens to be located near Cleveland, Ohio, but he consults with employers all over the country. In his bio, he talks about removing barriers for families to affordable and accessible quality healthcare and leading employers on the journey to combat America's sick care system. And both of those things really leads us to primary care. And he's doing a lot to bring primary care to rural communities and to his clients. And then Lee is the Chief Strategy Officer for the Health Transformation Alliance. He leads efforts across over 50 jumbo employers, 5 million employees, and has a variety of strategies that they do at HTA. One of them has been a focus on primary care, which we will get into. So thank you all for joining our reprise. While, I introduced each of you and technically, your bio, it'd be great for us to go around and have you each talk about the work that you are doing in primary care so that we can, let the audience know what are you doing, and then we'll dive in some more details about How do we strengthen primary care? How do we do whole person primary care? And really learn more about your current plans and plans for the future. So why don't we start with Lowell, the actual employer in the room, and tell us, what are you doing at Rocket Companies in this area of primary care?
Yeah, happy to share. Laurel, thank you for welcoming us again and having this conversation, which I think is important for me, not only as a clinician, but also in the employer space at the moment. So Rocket Group of Companies several years ago determined that it was important to have a different way of approaching its benefits, recognizing that, team members work long hours, that families were struggling to get to, their medical appointments, to mental health appointments, getting to the pharmacy. And so the strategy at that time was to partner with an on-site clinical organization, in this instance, Premise Health, to be able to bring those services or deliver those services on-site for their team members. And being the medical director of that site for some period of time allowed me to have, or allows me, I should say, to have a view of both sides. And so on the clinical side, I had the opportunity to lead that practice, which had primary care, which was a PCMH, patient-centered medical home. And also we had behavioral health and mental health. We had a pharmacy, or have pharmacy, a musculoskeletal team, which includes chiropractors and physical therapists, and an on-site pharmacy. In addition to those core services, we also have care navigation and care managers as a part of that team. And so we are fully invested in the on-site approach, the on-site care for our team members. And in addition to that, we have digital expansion for our team members that are remote. We are having a much more diversified and dispersed workforce on the West Coast and in other parts of the country. And so we are definitely leaning into the digital space. And so our organization recognizes the importance of ensuring that our team members' well-being is taken care of, and it's a very hands-on approach.
And when you say digital, are you referring to virtual access to primary care?
That's correct. Virtual access to primary care, but also in the pharmacy space as well, and also in the musculoskeletal space. We do those things via telehealth. We do pharmacy consults and clinical pharmacy guidance via telehealth as well. So.
Yeah, we have tools now that we didn't used to have, right, for reaching those employees that are not able to access your on-site clinic, right?
Exactly.
Lee, I know HTA and its members have decided primary care is of the utmost importance, and you all, my understanding is, have gone as far as to start putting together a network, a primary care network for your members. So tell me if I'm right about that, and tell us about that and anything else that you all are doing in primary care at HTA.
Yeah, no, I appreciate that. And for those not familiar with it, HTA is just we're a large nonprofit cooperative focused on trying to advance the mission of improving healthcare in the United States by realigning the incentive structures within American healthcare. And the challenge that many employers voice is, oh my gosh, I feel like I'm taking on all the rest of the economy, right? It's nobody wants to help me get good value for my people, right? Government doesn't, consultants don't, many of them, most hospitals are not interested in that. Most insurance companies not interested in that. And so they feel very alone. And one thing that has become very clear to us is, wait a minute, no, we do have allies in trying to take back our system. There's a civil war that's happening inside, across enemy lines, so to speak, within the provider scape. There's a civil war that's really being fought out on the front lines within primary care, and that is between value-based care and fee-for-service burnout. And the providers themselves are starting to reject the systems that they've been forced into, and pushing to try and change the incentive alignment, change the practice patterns within the industry to give people what they actually want and give providers the experience they've always aspired to have. And that is something that if we as employers want American healthcare to be anything better than what we have today, we have got to support that resistance. We have got to enable our employees and their families to use doctors who are trying to help us fix American healthcare. That should be the most de minimis thing that we do. If we're going to throw breadcrumbs anywhere, it ought to be there. And that's what we're working to do within HTA, is to make that scale so that any good doctor anywhere in the United States can tap into a national network with, or a national platform with millions of lives, grassroots, at no cost to that doctor, to be able to receive patients and be successful with value-based care.
Great. So we're going to get to it, but this is almost as much for the primary care clinicians as it is for the employers and the employees.
Yeah,
Anyways.
we've got to work together. That's a great way to think about it, Laurel.
Bryce, tell us about how you work with primary care, and I understand it's a central component of the model that you consult with employers on and encourage them to adopt.
Yes. Well, thank you again for having me, and it's good to be on the panel. As Lee is a part of, again, helps run HTA with the jumbo employers. As an employee benefits consultant, I'm more what would, many would refer maybe the middle market of employers, tied under an umbrella we call Health Rosetta. And it's really just a tribe of, maybe advisors and consultants, clinicians, providers, and employers that are same as Lee and his team, systemically trying to change the way healthcare is purchased and delivered across America for employees and families. And so do business across the country, yes, but I cut my teeth here in the state of Ohio in a what again is referred to as a rural county in Ohio, Ashtabula County, far northeast corner. Wildly enough, it has a federal designation of being part of Appalachia. And so I'm like dead center of Cleveland and Pittsburgh. Those that have been in the healthcare industry, the two big health systems in both of those cities. So the part of the story goes is our populations that we've served here, employer groups, public entities in particular, have been some of the sickest populations we serve. Socioeconomic, social determinants of health. The city of Ashtabula is like any big inner city, all the same problems. The county itself is 80% cornfields, and quite honestly, lack of primary care physicians. I spent a couple years serving on our county health department board, and come to find out that we are lacking primary care physicians. It's something like we have one PCP per 3,000 people in this county, where I think the national average might be 1 per 1,000. These rates are maybe a little older, but I think that's what it is. And so to recruit primary care physicians in a rural setting with not the greatest, we are the 8th poorest county in Ohio. So not, all physicians want to go back to a setting like that and live and work in a setting like that unless they're really mission driven, community minded. So my first direct primary care affiliation, where I brought in a DPC doctor to help serve employers, I literally rolled my sleeves up and had to help them figure out the software, the EMR, the practice software, the telemedicine software, put it all together and basically hold their hand to get going. But he was willing to do it. And within 12 months, I had him to his panel max of 600 patients. That's all he was right there. And so I got my experience there, and we basically fill a void each time we do this. But kind of giving you an idea, this advancement of primary care, direct primary care, advanced primary care, it's needed in cities and rural America. But rural America, my gosh, they need it the most, because you've got working class populations that don't understand healthcare, don't have doctors or nurses in their families, and they can very easily be taken advantage of in the fee-for-service business. So this is a very mission-driven focus for us, and it's a pleasure to be a part of this. I look forward to the conversation. So thank you.
Yeah, I think you hit on a big, my next question is about what problem are you trying to solve? And you've hit on a big one, which is access, and our rural communities are severely lacking access. We have one of our employers here in the St. Louis region, headquartered here, but they're national. They have 13 on-site clinics, and there are some locations where they only have 300 employees. And they see the value, because there's not access in the community, of bringing on-site, care to only 300 employees, and it's worth it for them. So following on that, so Lowell, back to you. Can you talk about what problem you were trying to solve? And maybe some of it was about rural access. And you talked already about how you're scaling it, but I think I'm most interested in the why the focus on primary care.
Yeah.
And I
Yeah,
think
that's a
I'm
good.
freezing, but I hope you can hear me okay.
Yeah, I heard the question. Yeah, and it is a great question. And to look at it, from a different perspective, because I think when we talk about care deserts, our mind shifts to rural communities. And I think I mentioned this in the initial conversations that we had. That you can also have urban deserts, right? Particularly for the primary care space. I did my residency here in the Metro Detroit area, and so I know this all too well, where as you are going through, residency, you start to see a lot of the older clinicians retire. And in a lot of those instances, they're either trying to partner with a younger clinician, so that they can maintain some income as they get older, or they're trying to outright sell the practice. In a lot of instances, those practices just didn't survive. In addition to that, the added layer of pressure comes from health systems not adequately investing in the primary care space, right? They're investing in, large surgical centers. They're investing in, areas of healthcare, areas of medicine that are high value or high cost, I should say. And so, what I have seen is that there's a significant investment in those spaces, but primary care is kind of on the back burner. And our organization recognized that folks were having a difficult time getting appointments. They were having a difficult time finding mental health providers. They were having a challenge with, getting to a local pharmacy because, right down the street, the Rite Aids just closed down. And so we had all of those challenges that we were seeing around us. And it was just important that for us to not only support the business, but also to support the communities around us. And so the idea was to really focus on that investing in our people, investing in their families, investing in our communities, and primary care baked into our benefits design and benefits plan was just a part of that. And it was especially helpful during COVID because as soon as the practice opened its doors, COVID hit about 4 months later. And so we were the only resource for the employer to do vaccinations when that, when vaccines were available, to be able to take care of, teams that were critical on-site teams so that the business function, would still be in place. So we really supported the organization through that very tough period where they still had to function as a business.
Yeah, so that reinforces the access issue. And Lee, when you were talking at the beginning about the situation for primary care physicians as well as for employees, is there anything you want to expand on about the problem that you were solving for, for the HTA members in particular?
There's a few. The first is that we know we have people walking into doctors' offices in cities and towns with their ID card, and they might be walking into the only doctor in town who's taking a new patient. And that physician is maybe the best doctor in town who's practicing value-based care, which is at the absolute core of everything we want our health plan to cover. And the doctor says, I'm sorry, I don't take insurance because insurance is destroying my profession. At best, I can do like a cash subscription model, or if your employer signs direct. And that employee says, oh, great, like healthcare is so broken, even the doctors are like getting out of it, right? And they walk out. And does that employee who's now frustrated, trying to find some urgent care or something to try and get some help, where they're speaking 5 minutes with whoever's on staff that day, to try and deal with what might be escalating comorbidities or whatever it is, whatever that person's need is, are they going to call the benefits team to complain? No. This is way bigger than my employer. And so I don't say a word. And when I speak with our benefits teams, a lot of them don't have any idea that any of this happens to be going on unless something personally happens to them, which suddenly brings it top of mind. Because none of your staff are complaining to you about this because they know that you can't, they don't suspect that you can fix it. And so the first thing that we want to fix is we want to make sure that any great doctor in any town is able to accept our patients and that our people are not being turned away. That's like the first thing that we just want that to happen because our plan should cover and we want to pay for good doctors. The second thing is solving for the balance or replacing what you're left with. If you are lucky today, you can access a doctor who is you're able to access a regular fee-for-service doctor through your Buca network. But often that doctor is owned by a system or a private equity group or something else within the establishment. According to the AMA, 36% of the time that doctor is paid on commission based on how much they can do to you that's billable. And they are paid to try and drive more referrals into a larger system in order to generate more revenue, all of which is completely backwards to anything that we'd hope for. The best you've got is maybe you can visit with an independent doc who doesn't have all those conflicts, in which case you wait 4 to 6 months a lot of times for an appointment and you get 5 minutes with the doctor. And that's the status quo. That's the default that we're offering today. We've got to do better.
Yeah, and Lisa, you start touching a lot on the financial model, and I might go a little bit off of our, scripted questions that we had planned because we have Q&A coming in already, and in order to make this of most interest to the audience. Bryce, some of the questions are, I do want you to expand more on what problem you're trying to solve if you haven't already, but people are asking about the financial model.
Yep.
And wanting to know what is your financial model. And someone has stated the obvious point that residents are not going into primary care in the way that we need them to because of the economics. And Bryce, you have said you've had some primary care physicians and clinicians come to you saying, how can I get access to employers? How can I have a different, get off the hamster wheel of fee for service? So can you talk a little bit about the financial model for
Yep.
like
Yes.
the work that you do for primary care physicians?
Yeah, so I'm going to make it plain, as a pastor would say. First off, back on the patient side of the financial model. So we all just identified how we're helping achieve the goal of filling the gap around access to care. The cost to care, this model significantly fills that gap, because employers who adopt this model of direct primary care, they're picking up the membership fee, just like Netflix or Hulu. They're picking up the membership fee for their employees and or their family members to sign up and see a direct primary care doctor. The cost of care to these DPCs is entirely free, 24/7, 365. It's same day or next day access to these doctors. And that means it can be virtual, text message, or face-to-face, because they're likely either an on-site or near-site clinic, or again, having the doctor's cell phone number over the weekend is going to save an ER visit, urgent care visit. My kid's going to get care right now. So financial for the patient is a win-win. On the physician side of it, and this is why, again, I've been fortunate enough. I've spoken the last maybe 3 years at the Family Medicine Educational Consortium, the Innovator Network with Larry Bauer. I'm doing my best to really promote residents into family medicine, doing this model immediately, not going to sign on the line with a big health system, because here's the financial. And you write this down. It's real simple. Now, anywhere between $75, and we're going to do the $75 number, but $75 to $100 per adult per month membership fee. I'm giving you the 75 to 100 because if my clients in Central Florida, to Maine, to California, Texas, Colorado, all our DPCs are in the $75 to $100 range per adult per month. At $75 per month, and if a value-based DPC doctor says, I'm going to cap at $500 or $600, real quick, and again, just so we can use exacts, I'm going to do it here, and I'm sorry to do it while we're talking, but 75 times, let's say 600 is $45,000 a month times 12 months. That's $540,000 a year to a single family medicine doctor. And by the way, the software, today's day and age, because of COVID, you have a practice software, an EMR, and a telemedicine software. And depending on which ones you choose as a doc, they all talk to each other. They're integrated. So maybe you hire one MA, maybe you don't. Maybe you just hire someone to answer the phone or something. But you don't really have to, because the software does it for you. It's all integrated. $540,000, you're going to have some overhead, maybe an insurance policy, a lease, but very minimal investment in the brick and mortar of your practice. But I would imagine that amount of money, less maybe, I don't know, $100,000 a year and some expenses, you're still, call it $400,000 plus a year financially. That's probably pretty good compared to what a health system wants to sign you on as. Yeah, they might pick up some of your debt, but the freedom and the autonomy to practice the way you want, to do the proper patient care. That's what this model does, is allows you to practice at the top of your license, not, as Lee said, not a hamster on a wheel, just seeing 30 to 40 patients a day and referral and this and that. So the financial model is way more attractive on this end in the value-based model than the fee-for-service model. And we bat close to 1,000 when I can get in front of a doc who's interested in the model to coming across the line and starting their practice.
Great. Thanks. I think that specificity was probably helpful to a good portion of our audience. Lowell, so back to you. Can you talk about your financial model and then tie that into the results that you've achieved? Both if you could talk financial and in improved health as well.
Yeah, certainly. I think Bryce touched on some of this where, we as employers, we carry the most of the cost. For most of the services that we provide, it's free to our employees. In some services or some instances, there's a minimal copay, a $5 copay or a $10 copay. But it is a fraction of the cost of what they would spend in the community. When we talk about our pharmacy spend or cost, it is a big hit. I mean, we always laugh that Tuesdays there's a run on the pharmacy because they stock on Monday evening, and by the time as Tuesday afternoon comes along, their shelves are empty because the cost is so beneficial for them that it's unbelievable when you compare going into a local pharmacy or a community pharmacy. So the cost for us, the way that we look at this is that if we put an investment in primary care upfront, then downstream, we're going to see savings. We're going to see that reduction in ER visits. We're going to see the reduction in urgent care visits. We're going to see, this reduction in folks, their out-of-pocket spend being higher when they go to the pharmacy or to some of the other services in the community. And so we find that if we make that investment upfront, that overall it is beneficial for the organization from a spend standpoint. But from a clinical standpoint, we've seen some significant results in terms of chronic condition management. And that is grounded in our approach in using care managers to really guide folks through their care, and then condition managers as well. So we have specific condition managers that are diabetic trained nurses or nurses that are focused on hypertension. We even go as far as some folks that might have wound care and guiding them through that process as well. So again, very, very hands-on line of service, if you will, that we have through our benefits team.
Great. Lee, maybe you can talk about what has been the uptake and the response. I mean, I know that running a membership organization myself, I know that we take on initiatives when we understand that our employers are asking for it or they have a need. So I'm assuming that that's how you all embarked on putting this network together, is that your employers said there was a need. What has been the response and the uptake, and how is it going?
It's been excellent. I would say the key thing is we built around what a large employer could do. We were working with a Big Four accounting firm, and with about 100,000 lives as one of the early adopters here. And they said, if we're going to get this done before like 2029, we need to have it avoid what I call the four horsemen that slow and delay any great idea. And that is no data sharing. We don't want a custom billing process. We don't want a plan design change. And we don't want to do contracting, like red lines and everything with all of the contracting teams. If we can avoid those four, it should be impossible, but if we could avoid those four, we can get this done quickly, easily. And so we set out to build with those constraints already in place, and succeeded. It was not easy. It took a long time, but we succeeded. And now it is a simple opt-in. So any employer, and this goes really for any, if there's an employer listening to this right now, either live or recording, or if you're a physician as well, it costs, there's no cost to opt in a new provider if they meet the minimum requirements. And there is no cost to an employer to be able to opt into using this network as well. And then once activated, we do have to implement. So we work with your carrier, Blue Cross, Cigna, Aetna, whomever, to make sure that the payments can go through, that the claims work. All eligibility is just checked at point of sale. And the one thing that an employer must do, and this sounds like not a lot, but it is kind of a lot, is you've got to let people know about this. And what we have seen through multiple deployments is it doesn't have to be big, it just has to be consistent and ongoing. And consistent and ongoing is not easy to do. But effectively, we need to send out at least an email once a month. It doesn't have to be fancy. It can be 2 or 3 sentences. You can have a spelling error. It doesn't have to be fancy. We need an email to go out once a month because the engagement we've seen within this program is different from any other program I've done. If we put in a fertility program or a second opinion or mental health, we do a big run up, we do a few webinars, and we notify everybody, and we get 10% engagement, and we're off to the races. And then if we communicate it over and over again, it's like nobody really cares because they got it. They already saw everything. With this, if we do an enormous campaign to deploy it, you get 1 or 2% opt-in. And I feel like a big loser after that. I'm like, oh, nobody wants it. But then the next month we send out another thing, we get another 1 or 2%, even with no run up. And the next month, another 1 or 2 or 1 or 1.5. And again and again and again. And what it turns out is that 99% of people ignore it. Whenever you send something out, 99% of people ignore it because they're not sick right now. And then 1% pounce on it like they're drowning and it's a life preserver. And each month there's a different 1% who's drowning. And so over time, you can get a third of your population using advanced care and a third want to, but you can't get it fast.
Yeah, I think you just outlined a challenge every employer has when they're introducing solutions that are really designed to help employees. So we talked a lot about the mechanics and the financing of this. I'd like to talk a little bit about the actual care being received. And I'd love us to, I mean, I know I've heard patient-centered medical home, there's advanced primary care, but ultimately we want to be approaching the whole person. And this includes integrating behavioral health, physical therapy, some of the other, services we've heard mentioned. So I'm going to have you each talk a little bit about, maybe starting with you, Bryce, the approach to how you think about whole person care and integrating behavioral health as it relates to primary care in the model that you promote with your clients.
Sure. Yep. So, what we found, a lot of the docs, they'll, I guess in their agreement, with our employers, they'll say, hey, we've either been trained in, on the side of mental health, behavioral health, or we do not, and we're going to need to refer out to it. And so one thing that I, haven't mentioned, we're big promoters. We want to do as much under that shingle as possible with the DPC. But if the doc does need to refer out, we're fortunate enough, we do have similar to Lowell, where we've got a kind of a navigator that the doctor can hand off to a nurse navigator and find that person immediate care. Sometimes, and a lot of times, if it's immediate, we'll utilize virtual services that may provide, again, folks in rural America may not have a whole lot to choose from, or don't have the ability for transportation. So virtual behavioral and mental health care has been really a big staple for our team and the health plans that we design and create. And other times, maybe perhaps there are some options that we can refer patients to. But overall, I want to say this. We're big on listening to an employer, especially ones who maybe have a little greater sophistication of purchasing these types of services. Like, what do they want to see? What do they hear in the human resource department that people are struggling with? Is it, do they need more naturopathic routes or chiro care? Is, the limits are too low, or people don't go at all because it's all deductible instead of a low or affordable copay. So the ability, in my role as what I kind of refer to sometimes as a plan architect, as a consultant, plan architect, is to create a high performing plan design for these employers. And so, middle market employers have a little bit more maybe flexibility or autonomy that they want to create some of these things, or tell us what they're looking for. So I guess to say flexible, we want to hear what their needs are. And sometimes, as not all middle market employers have it, but sometimes if they do have access to their claims data, we can see the drivers of their costs. Is it anxiety, depression? Is it, what are the urgent emergency room visits going toward? What are the disease states we're struggling with? If they have that sort of claims data, then we can help create the plan design based on that.
Lowell, how about you? Thinking about, whole person health and integrating behavioral health.
Yeah, sorry about that, Laurel. Just trying to get off mute there. Yeah, I'll definitely dive into that, but I think that there were a couple of questions that were in the chat that I saw that popped up that I will try to just hit very quickly as I dive into that. One, I think there was a question or comment about getting folks into primary care out of residency, and I think a part of that has to do with understanding total rewards, total compensation spaces, and educating folks that it's not all about the financial, remuneration, but there are other rewards and other things that you can package. And I think when you come out of residency, total rewards is something that you don't even hear about. What is the complete package of your compensation? And so we need to encourage organizations to do that more. The second thing that I saw there was with privacy and anxiety with your employer having access to your health information. We don't have any access to that. We look at claims data. Our partners certainly don't share any insight into employee health. By law, obviously, but just by design, it works out great, and we try to market to our team members as much as we can. And that's what drives a lot of the utilization, consistent conversations, marketing, and strategy around it. But to your question with regards to the spectrum of care, I think there was a question there as well. We do have chronic care services through primary care, our care managers. We have on-site behavioral health. We have for psychologists. We have a dedicated psychiatrist that's in the community, but that we rely on for higher levels of care in the mental health space. We have the musculoskeletal team. We have the chiropractor. And then we have the on-site pharmacy, as I mentioned, but not only are they doing the pharmacy services, they're also doing clinical pharmacy services. So they're able to collaborate not only with the primary care, but also with the mental health professional to say, hey, we need to make adjustments to this person's medication, or they have been on these medications for a period of time and they're not seeing any significant benefit. Or there's concern with, drug interactions. So, when you have that full scope and comprehensive umbrella, so to speak, with your population, you start to see significant results in a very short period of time. And so we've intentionally embedded behavioral and mental health as a part of our services.
Yeah, it's really critical. We just had a big program in St. Louis for primary care physicians about integrating behavioral health, and there's so much good work being done on that.
Wow.
Now that we recognize, right, the connection.
Yeah.
You gonna say something, Lee?
No, just kudos. That's really interesting.
We have so many questions that I think I'm going to, and thanks Lowell for catching some of them. I'm going to shift to the questions. So Lee, I'm going to send this one to you first. Can
Okay.
you talk about overcoming obstacles to scale? For example, we have 2 or 3 good DPC docs in our community, and 1 or 2 you wouldn't want to see, but that's not enough to serve a large employer. So what do you need to do to get to the critical mass of having enough docs to serve multiple large employers, which is somewhat what you're trying to do. So maybe this is a good question for you.
Yeah, the advice that I would share there is one, you can connect into the billing service right now. It's appley.com. We're not connected with them. That's just the billing service. Many people on the call are probably familiar with that. It's APALY .com. You can set up an account there, input your routing and account number, and accept through the terms of service. And in less than 30 minutes, you can be operational to be able to receive patients from any employer who's opted in. Then, so if all 3 of you are connected there, you could then go to the local employers in your community, and any of those who are interested could opt in here as well. Now, are you going to get 4,000 employees overnight? No. The way the program is set up is once a patient starts using you, then you begin collecting pay. And as I articulated earlier, it happens very slowly. It's like consistently, it's like 1% per month. You don't turn on all of them all at once. Now, in some cases where we need to seed a new doctor, like Bryce was referring to earlier, we might need to begin 500 subscriptions all at once, and that's okay. Nevertheless, if you've already got a location and it's up and running, this is a very easy way just to bootstrap into more and to get growth. So you could activate a few of your friends in the community who might have a few hundred employees or 1,000 employees and get them to start notifying their patients each month. And you will have at most maybe 2% in a given month will want to come in and start using your services. That's very gradual. Once you tap out and fill your panel, then you, or as you're getting close to doing that, start looking to hire someone else. You could expand your location to another location, or you could just expand some of the staff within your location or expand your hours. That's a very organic way to slowly grow and accommodate additional patients. And it would allow you to grow and develop over time without having to go get money from a private equity firm, so that you can organically grow your business and be able to handle any size of employer that might come up.
And I'll add to that, Laurel, just, if docs are kind of sick and tired of being sick and tired with a health system, if they really examine their employment agreements, a lot will find their non-compete language really is from one health system to another health system, not necessarily from a health system to a direct primary care, not fee for service, independent practice. So we've seen a lot of recruitment happen because of there's a free out that they can transition to, direct primary care, value-based model.
Yeah. Here's a pretty broad question. Anyone can jump in on this. Discuss how federal policy is impacting employer efforts in this space.
Lee, you want to do that one, or?
I can do that where at a national level. So the main change that we've seen here is, and the biggest sort of burr in the saddle is absolutely HSAs, health savings accounts, and the first dollar coverage rules. So this was one of the hardest things that we had to figure out, is how do we make good, strong compliance on HSAs because especially many of my employers, if they lose their HSA status because they violate first dollar, it could be 100 million a year in fees and fines and lost charges. So it's a very, very big deal to stay compliant with HSA law. And historically, DPCs have just been in parallel to it. The big, beautiful bill came out. What does it say? It says that an employee who has money in their HSA and wants to use DPC, but doesn't want to pay cash for it on their credit card, or maybe they are, but they don't love it, they can now use their HSA to pay for direct primary care. They can pay for those membership fees. What I love about that is it provides more choice for people who have these accounts. What is sad about it is that they shouldn't have to deplete their entire HSA for $1,000 a year to access primary care, because they're receiving at least half of the care, sometimes a lot more than half of the care received by your doc is safe harbor, which means you shouldn't have to accumulate that against your deductible, and you shouldn't have to take that out of your future retirement to pay for it. But it's better than nothing. So you pay every single month subscription as if it is 100% sick care, and you deplete $1,000 per person out of your retirement savings. The way that we fixed this, and for any employer, this is we friends don't let friends force it out of the HSA. That's not the way to go. What we do instead is we say, look, if you have an HSA, we're going to bill the monthly fee every month. We're going to treat it as safe harbor. It covers all care except sick care, significant sick care, which is the IRS rule that if it's significant sick care, that must be paid out of the HSA. So we say we're going to pay a monthly fee, PCMH, patient-centered medical home fee. We're going to cover that each month, and it's going to be great. And that fixed subscription fee covers all care except for sick care. And then when sick care occurs, we will pay the fair market value of that. And that way, we only take out of the HSA what must be absolutely removed out of the HSA per the IRS law, and everything else is fair game, it's safe harbor, and it's paid by the employer. And by doing this, instead of taking $1,000 a year per person out of their HSA to pay for DPC, we take maybe 100 or 200, and we're totally fully compliant with every element of the law. And that has worked very well for us.
Thanks, Lee. That was a great summary of the big, beautiful bill and the challenge with high deductible plans and HSAs. And that was specifically a question that came up. So thank you.
Oh, that's
Lowell, I have a two-parter for you. We're going to answer two questions in one. Is your on-site clinic administering GLP-1s and are offering a program on GLP-1s? And then secondly, how are you working with clinical pharmacists and pharmacists? Do you contract with an organization? I know some of the premise clinics have on-site pharmacies. So maybe you can address both of those points.
Yeah. I'll start with the clinical pharmacist first. The pharmacy structure is a part of the premise suite of services. Now, some organizations may not want to use or have the pharmacy services, so they can have that carved out in a different way. We've decided to have premise pharmacy services, and that's through their partnership with Walgreens. So it's actually a Walgreens pharmacy, but it's built out as a premise pharmacy within our space. And what they do is they do nationwide shipping, 24-hour or within 24 hours, FedEx, to home or to door shipping for our team members across the country. But we've been very fortunate to have, 3 PharmD, clinical pharmacists in our space, in addition, to their expanded team. And so they are very engaged in the education of our population. And so they work very closely with our care managers, our care navigators, and the primary care team and behavioral health. But their primary wheelhouse is within that care management, care navigation space, and education for our team members. And so we've been very fortunate to benefit from having those 3 PharmDs within our space. if that answers the question. And then the question about GLP-1s, I think every organization is struggling with the GLP-1s. We do have GLP-1s, obviously for our diabetic population, but also for our weight loss or obesity population as well. And we do have all of the available GLP-1s. We made a decision that it was important for us to continue to provide those for our team members, but ensuring that there's some wraparound to that. Not just providing it. And as we know that there are different levers that you can pull at the benefits design level. There's the actual clinical level. There is the PBM level with prior authorizations. But the big component of that is a program that we have, again, partnered with Premise for called Beyond Weight. And so that's diet, nutrition, movement, and also behavioral health. To wrap around the prescribing of GLP-1s.
Great. That seems to always be a question, no matter what, seems like for employers, no matter what the topic is. One last question, I know we're running out of time, is related to data. Are direct primary care practices able to provide the data that large employers need to manage the health of their population and their program? So I don't know, Bryce, maybe throw that one to you.
I'll start, and I may even hand the baton to Lee. They may have it coming in through the Appley platform. But so, again, a lot of these physicians they leave the health system where they're having to deal with prior auths and insurance companies and all the documentation. It's what they want to get away from. So what we do is we ask in our contracting of DPCs that there are going to be certain things that they will report on. So things such as, again, avoided urgent care and emergency room visits. So it might be after hours or on the weekends. Maybe someone thinks that they needed emergency room, but really and truly they just needed immediate care from the physician. We look at how many consultations, both virtually and in person. We're capturing things. So a lot of these physicians pay for a service to have curbside consults with other specialties. So we look at, the number of these curbside consults and what type they're having. But at the end of the day, there's not claims data most of the time in the arrangements that we make. It's really just from a bigger perspective, again, not from the employer perspective, but from, again, the side of the coin that I am on, representing as the consultant. We also have a data warehouse that we're working with. So all claims data is going in, being fed. We can see what's happening. It's kind of really called population health, or again, looking at risk stratification of the members that are underneath these DPCs. And we can really gauge and see, are they getting worse? Are they getting better? Are we closing gaps in care, coordination of benefit? Like, we can actually determine, hey, are these folks getting proper care? And so, I would say to you, yes, there is less of insurance and maybe claims documentation, things like that, in this model. However, there's still these docs, unfortunately, do still need to be accountable to the employers in which they're contracted with to do the work. So I hope that helps. I know that I kind of give a bit of a gray area there, but that's really that's where we're at. So Lee, I don't know if you want to add.
This was a huge area of reconciliation because employers need data, and many docs see data collection as a remnant of everything wrong with healthcare, because it gets sort of thrown out with the bathwater of fee for service. The way that we've reconciled this is we just say, look, just report to us whenever a significant event occurs. We have to do it for HSA logic anyway. So if you have a significant interaction with a patient, you don't have to report all your text messages, but if you have a significant interaction with a patient, report it and tell us broadly what was wrong. It's 1 or 2 clicks. It takes 30 seconds. And in exchange for that, we'll continue to pay a membership, and it will give us a chance to see when major interactions are occurring. We see that our docs are reporting about 1/3 to a half of all the interactions they have with patients, which isn't bad. And we're able to see that come through in that reporting. And then some of our docs have ancillary reporting they'll supplement that with, but that seems to be about the right compromise that we've come up with.
Great. Well, we're over time. We could keep talking. I want to thank you all for joining this conversation, and back to you, Todd, to close us out.
Yes, thank you so much, Laurel. Thank you, Bryce, Lowell, and Lee, for joining us this afternoon. And thank you all for joining this conversation. I hope you learned as much as I did from it. As a reminder, we will be posting this webinar on the pcc.org. You'll also be prompted to take a survey when you close out of this webinar, and we hope you will go ahead and do that. Thank you all very much, and I hope you all have a wonderful afternoon.